So as we have just gone over the characteristics and the histology of cardiac muscle, we now know that cardiac muscle is a type of involuntary muscle, which means that we do not get to consciously control the contraction of the muscles in the heart. So if we are not voluntarily contracting the muscles of our heart, we have to have something that's keeping the heart pumping on its own, and that is known as the cardiac conduction system. The cardiac conduction system consists of very specialized cells that are designed to keep the heart beating at all times. We describe these cells as self-excitable and autorhythmic. Autorhythmic fibers repeatedly generate action potentials that will constantly trigger heart contractions. Since the chambers of the heart and the way that they pump needs to be very specifically coordinated, we have to have a conduction system that's set up to direct the pumping of blood through the heart. So it is thanks to the conduction system that allows us to get these action potentials through the heart muscle and continuously get blood pumped through the body. Now, the conduction system is made up of several components, and they are shown over here. The first component is known as the sinoatrial node, also known as the SA node. The SA node is found in the wall of the right atrium. Just below this, we'll find the atrioventricular node, or the AV node, and that's going to sit between the atria and the ventricles. The AV node connects to another structure known as the atrioventricular bundle, also known as the bundle of His. The bundle of His will split into the right and left bundle branches, and those will course through the interventricular septum. And then from these right and left bundle branches will project what are known as the Purkinje fibers. So this is the conduction system that our heart uses to continually pump blood. You can see that in the way that these different components are found within the heart, they are able to propagate action potentials and excite the surrounding muscle to generate consistent contractions. These components are critical in order to facilitate the coordinated action of the heart chambers. So the sinoatrial node, also known as the SA node, is what's referred to as the pacemaker of the heart. And I guess I could more accurately call this the natural pacemaker of the heart, as this is the component of the cardiac conduction system that fires action potentials the fastest, and therefore it will set the pace for the contraction of the heart chambers. So based on its location, the SA node will fire action potentials at a particular speed, and it's roughly going to be 75 times a minute. And that is where we get a natural heart rate of about 75 to 80 beats per minute. Now, based on its position in the wall of the right atrium, when the SA node fires, it's going to propagate its action potential along the walls of the atria, and that's going to depolarize that cardiac muscle and lead to a muscular contraction in the two atria. And you can see these arrows are showing you the propagation of this signal. Now, eventually, this signal is going to make its way down to the AV node, the atrioventricular node, in between the atria and the ventricles. And every single time the SA node fires an action potential, that will hit the AV node. Well, when the AV node is hit by the action potential from the SA node, that's also going to depolarize the AV node and facilitate the continuous propagation of this signal down into the ventricles. So the AV node is very helpful in getting that action potential down into the ventricles. Once the AV node is excited, it's going to pass this signal down to the bundle of His, into the right and left bundle branches, and then into the Purkinje fibers. And the contraction of the ventricles is going to begin at the apex, so that it forces the blood into these major vessels. So again, taking the signal from the atria to the ventricle is done primarily by the AV node. So since it is the fibers in the SA node that fire action potentials the most frequently, they are going to set the pace of the heart, and that's why we call them our heart's natural pacemaker. All of these autorhythmic fibers can serve as a pacemaker. In fact, if the SA node were to be destroyed, the AV node would actually take over the conduction of the action potentials through the heart. However, the AV node does not fire as quickly as the SA node does. And since the SA node fires the fastest and the most repetitively, that's going to set the pace of the heart contractions. Now, as described down here in this box, there are lots of outside factors that will also regulate our heart rate, or I should better say, affect the heart rate. The sympathetic division of the autonomic nervous system will dump norepinephrine on the heart, and that's going to increase heart rate significantly. However, we should look at these outside influences as influences, not as a controller. It is the autorhythmic fibers that control the pace of the heart. So on this slide, we have some conditions that are related specifically to the conduction system of the heart. And we'll get started here by explaining arrhythmias. So normally, established by the SA node, the rhythm of the heart is called the normal sinus rhythm. That's just a phrase to describe how the heart is supposed to be beating naturally. Arrhythmias refer to abnormal rhythms of the heart, and those result of a defect in the conduction system. Arrhythmias may lead to the heart beating too slow, too quickly, or just completely irregularly overall. So we can imagine if one of the components of the cardiac conduction system is affected, it's not going to be able to propagate the action potentials as effectively, and that can lead to arrhythmias. We will see fibrillation as a type of arrhythmia. This refers to a very, very rapid contraction in one of the heart chambers. We can have atrial fibrillation and we can have ventricular fibrillation. Specifically with atrial fibrillation, the atria might beat 300 to 600 beats per minute. And as a result of this, the ventricles will also speed up. Atrial fibrillation reduces pumping effectiveness of the heart by at least 20 to 30%. If the pumping of the heart chambers is not in unison, the effectiveness of the heart is significantly going to drop. We also have ventricular fibrillation, which is one of the most deadly types of arrhythmias that there are. Ventricular contraction is not coordinated with ventricular fibrillation. Ventricular fibrillation is often treated with defibrillation, and that is done by a defibrillator. A defibrillator is going to pass a very strong, very brief electrical current right through the heart, and that can prevent the ventricular fibrillation. As I mentioned a bit earlier, the ectopic focus is when one of the other components of the conduction system takes over the beating of the heart. Now, if the SA node is defective, it's not going to pump at 75 to 80 times a minute. However, the AV node will pick up, but that's going to be at a slower pace. So the heart will not be as effective if the AV node takes over. Just as it sounds, a heart block is an arrhythmia that occurs when there's a blockage in the electrical pathways between the atria and the ventricles. This leads to different pacing in the atria and the ventricles because the signals from the SA node aren't able to transmit into the ventricles. So therefore the ventricles end up beating slower than the atria because they're going to be going off of the signals that are coming from another part of the conduction system. So now that we know that it is the conduction system of the heart that keeps the heart beating, we're going to start to look at the action potentials that are propagated through the heart. Now recall that we did learn the action potential in ANP1. We discussed the different sodium and potassium channels and which way those are going to flow and how they're going to flow in and out of the cell to give us action potential propagation. And in the cardiac muscle, it's going to be very similar. However, there are some differences with the action potential in cardiac muscle compared to skeletal muscles. So the first major difference that we can already start to see comparing a skeletal muscle action potential to a cardiac muscle action potential is that the depolarization here in cardiac muscle is followed by a plateau stage instead of the rapid repolarization that was facilitated by potassium channels. We'll still have the rapid depolarization, but we're going to have that plateau phase that's in between depolarization and repolarization. And it is calcium channels that facilitate the plateau in the cardiac muscle action potential. So I am hoping that you all have not forgotten what you already learned in ANP1 about the skeletal muscle action potential, because we're going to take some of those ideas and translate them to this picture also. So remember that the membrane potential is roughly at negative 90 millivolts. Membrane potential refers to the electrical difference between the inside and the outside of the cell. So we would say that normally our cell has a negative 90 millivolt difference between the charges on the inside and the outside of our cell. And that's about what we see right here. This is right between negative 80 and 100, so we're going to say that that would be negative 90. So that's our typical resting membrane potential. Now, most of what we see about depolarization here is going to be fairly the same as what we saw in AMP1. It is these sodium channels that are going to open to allow those positive sodium ions to flow towards the inside of the cell that will cause the depolarization to a much more positive membrane potential. These channels that facilitate this depolarization are called fast sodium channels. We assign the speed with the cardiac action potential because some channels will act faster than others. So these fast sodium channels facilitate the very rapid depolarization to a more positive membrane potential. Now, at this point, what we're used to seeing would be a closing of those sodium channels and an opening of potassium channels. And some of the potassium channels will open at this point. However, we're also going to have calcium channels that are opening at this point as well. And this is what facilitates the plateau phase. When the calcium channels open, specifically voltage-gated slow calcium channels, when those calcium channels open, they're going to allow for more positive charges to flow towards the inside of the cell. And that's what maintains our membrane potential at this more positive level. So it is true that some of those potassium channels will open, and that's essentially going to keep us at the plateau, as potassium channels will be opening and allowing potassium to go out of the cell, and some calcium channels are now going to be opening, allowing calcium to go in. That's going to keep our membrane potential at the exact same spot. Now, when we get to the repolarization, those voltage-gated slow calcium channels are going to close, and at this point, additional potassium channels will open, and that will facilitate what we know as the repolarization. So in comparison to skeletal muscle, we just have the calcium channels that are added in between the opening of the sodium channels and the opening of the potassium channels. In fact, the calcium channels and the potassium channels do open up at the same time, but it's not all of the potassium channels, and that's what keeps this plateau phase at a more steady membrane potential. And once those calcium channels eventually close, more potassium channels will end up opening and allowing additional potassium ions to flow out of the cell, taking those positive charges with them and decreasing the membrane potential back to the negative 90 millivolts that we saw at the resting rate. Now, from this slide, we want to understand that when there is a depolarization of muscle fibers, that's going to indicate that we have some type of muscle contraction taking place at the same time. And when there is a repolarization, we can look at that as muscular relaxation. So we're going to use our new understanding of the word depolarization and repolarization when we start to look at the electrocardiogram. This is also referred to as the ECG. You can also call this the EKG based on the way that it's written in German. But don't get confused, these both mean exactly the same thing. So the EKG is a very useful tool that we can use to assess the functionality of the heart. What we're sensing with the electrocardiogram is the voltage that passes through the heart per unit time. And that is what we're looking at here on this picture. So let's start to break down what we see. On the y-axis, we see voltage being measured, and on the x-axis, we'll see time in seconds being measured. And voltage will be measured in millivolts. So you can see that as time progresses, changes in the voltage of the heart are going to produce these three major deflection waves that are very, very characteristic to the EKG. The three deflection waves we have are the P wave, the QRS complex, or the QRS wave, and the T wave. Now, each of these deflection waves shows a different moment in the cardiac cycle. It shows different voltages going through different parts of the heart. So we'll actually be able to translate this information into what's actually going on in the cardiac cycle. So the P wave is shown here. You can see it's labeled. This is the P wave, and this is going to be the first part of our ECG reading. The P wave shows us the depolarization of the atria, and this is facilitated by the SA node propagating action potentials out to the AV node. And we'll see, with this little key in blue here, this will show us atrial contraction right in the same place as the P wave. Now the next deflection wave we see is the QRS complex. And the QRS complex is always supposed to be very, very sharp. The QRS complex tells us that we're going to have the depolarization of the ventricles. So that means ventricular contraction, and you'll see the QRS complex will be right in line with ventricular contraction, which is shown with this yellow bar. So we're now seeing the signal sent from the AV node go all the way down to the Purkinje fibers, as the Purkinje fibers take that signal out to the walls of the myocardium in the right and left ventricles and cause the contraction of the ventricles. So that is what's shown by the QRS complex. Now we'll also have the T wave, and the T wave is going to be indicating ventricular repolarization. So since we have ventricular repolarization shown in one of our deflection waves, you might be wondering where atrial repolarization is found at. Well, it's not that we have skipped over atrial repolarization. In fact, atrial repolarization is going to happen during the QRS complex. However, the QRS complex is going to obscure the atrial repolarization, so we won't really see that shown on the EKG. But we do know that it is found right here during the QRS complex. Now, the whole purpose that we learn the EKG is so that we can know what a normal heartbeat is going to look like in terms of voltage over time. So we want to be able to see normally, this is what a heartbeat is supposed to look like. This is how the voltage is supposed to go through the heart. And so the real reason that we learn about the EKG is that different changes in the EKG reading can indicate different types of issues or damage to the heart. As we get towards the end of this presentation, I will go over a few of those examples with you. But for now, I just want you to get an idea of what each of these deflection waves refers to and which events occur during them. So this slide will hopefully be very effective in showing you how we get this EKG tracing from the events that are occurring in the cardiac cycle. So we'll start here at number 1, which is the depolarization of the fibers that produce the P wave. So the firing of the SA node, which leads to atrial contraction. As we start to propagate this action potential, that's going to change the membrane potential and the voltage that's passing through the heart. You can see here in number 2, we've produced an entire P wave after the atria have contracted. Now here in number 3, we see the ventricular chambers are going to get depolarized, and that is showing us the QRS complex. Don't forget that the atrial repolarization is occurring at about the same time. Number 4 shows us that once we have depolarized the cardiac muscle in the ventricles, that's going to finish up the QRS complex. And 5 and 6 will show us ventricular repolarization as we start to make the T wave. So hopefully this slide is very helpful in showing you what events occur at what times and how we can translate those events from the EKG tracing. So now that we've discussed autorhythmic fibers, the anatomy of the heart, and we've discussed the EKG and the different events that occur within it, we're now going to move on to the cardiac cycle and start to tie all of these things together. The cardiac cycle refers to one individual heartbeat. And to break this down very specifically, the cardiac cycle specifically is going to include the contraction and the relaxation of both of the atria, as well as the contraction and the relaxation of both of the ventricles. Now, some new words for us here that I'm going to add to our vocabulary is systole and diastole. Now, systole is just a fancy word for contraction, and diastole is a very fancy word for relaxation. So systole just refers to contraction of a chamber. Now, we can look at the cardiac cycle in many different ways. We can look at it in terms of the electrical events that occur, and that would be the depolarization and the repolarization of the action potentials as they pass through the different chambers in the heart. We could break that down even further and talk about that in terms of the potassium, sodium, and calcium channels that are opening and allowing different substances to flow in or out of the heart. So that's just one of the ways that we can break down the cardiac cycle and start to really understand what's going on in the heart as it's pumping blood. We will also see that one of the dictating factors that facilitates the passage of blood through the heart are the different pressure changes and volume changes that are occurring inside of the heart. Pressure and volume, as we know, are directly related. And it is specifically these pressure changes that determining when the valves are going to open. In fact, the tricuspid and bicuspid valves will only open up when the pressure inside of the atria is greater than that of the pressure inside of the ventricles. And the volume changes that we see in each of these chambers as blood passes through the heart are going to indicate where blood can be found at what times and how much blood is found in each chamber, as well as how much blood is getting pumped into our vessels. In terms of the mechanical events, that's pretty much describing what's going on up here, the contraction and relaxation of each of these chambers. But one thing that we haven't discussed yet are the heart sounds. The heart does make sounds, and that's why whenever you go into the doctor's office, they will take what's known as a stethoscope and listen to your chest. The heart sounds are caused by the turbulence of the blood associated with the closing of the valves inside of the heart during the cardiac cycle. There are, in fact, 4 heart sounds. However, only the first 2 can be heard audibly with the stethoscope. These first 2 heart sounds are often described as the lub sound and the dub sound. Now, I know that sounds a bit odd, but when we do listen to the contraction of the heart and the cardiac cycle, we can hear 2 major events. And so simply based on the way they sound, we get our 2 sounds sounding like a lub-dub. Now, I have never been a big fan of the lub-dub. That's never sounded particularly scientific to me. So I call these sounds S1 and S2. And in case you were wondering, there are lots of other people that call it S1 and S2 as well. That's in your book. So that's what I'm going to be referring to these sounds as, is S1 and S2. S1 is the first sound, and that is caused specifically by turbulence of blood that's associated with the closure of the 2 AV valves that are closing just after the contraction of the ventricles begins. And the second heart sound, which would be labeled as S2, is caused by the turbulence of the blood that's going to be associated with the closure of the SL valves at the beginning of ventricular relaxation. So let's take a look at this next slide so that we can see a nice diagram of all of these events occurring to represent the cardiac cycle. So I know this is a very big diagram, but we're going to take some time to go over this, as each of the different parts of this diagram are going to show us a different stage in the cardiac cycle. This diagram is going to be very, very helpful in helping us to understand what heart sounds are going to be heard from which events, what events are going to occur with the EKG, and more specifically, the phases of the cardiac cycle as we change the pressure and the volume inside of the heart. So I'll first go ahead and start right here. This little bar shows us that we've got atrial systole, ventricular systole, and the relaxation period, which would include ventricular diastole. These are all color-coded in these columns to show you what events occur at what times. So first and foremost, something that we've already gone over, the ECG. So the ECG shows us the P wave, the QRS complex, and the T wave. And the EKG tracing will continue to repeat as long as we want it to. We know that the P wave is going to indicate atrial depolarization, the QRS complex is going to indicate ventricular depolarization, and the T wave is going to indicate ventricular repolarization. So you can see each of these pictures in line with the events that are occurring during them. However, let's take a look at some of these new concepts that we're adding to the cardiac cycle. I think the best place to get started on this will be in the phases of the cardiac cycle. So we have a few different names for the stages of the cardiac cycle. So each phase of the cardiac cycle indicates a particular event and how it's occurring within the heart. Just as we started our heart anatomy with the right atrium, that's what we're going to start to look at. We're going to focus on the atria first. So the first phase of the cardiac cycle refers to atrial contraction. This is implying that there's already blood in the atria, and the atria have started to squeeze, and that's going to push blood past the tricuspid and the bicuspid valves into the ventricles. What's required for atrial contraction to facilitate properly is that the pressure in the atria must exceed that of the pressures in the ventricles. And that's what allows our tricuspid and bicuspid valves to open up. Now, once blood has entered into the ventricles, the next stage is a very, very unique stage called isovolumetric contraction. We know that ventricular depolarization is going to lead to ventricular systole. So as ventricular systole begins, the pressure is going to start to increase inside of the ventricles, and that's going to eventually push blood against the open AV valves, and that forces them shut. Now, once the AV valves have shut, both the AV and the SL valves are closed for a very short amount of time. But in this short amount of time, the ventricular walls are contracting and rapidly increasing the pressure inside of the ventricles. We call this period isovolumetric contraction because the muscle fibers are contracting and exerting force, but are not shortening, and therefore that muscle contraction is isometric. The other implication of this stage is that now that all four of the valves are actually closed, the volumes inside of each of the heart chambers stays the same. Now, once the pressure in the ventricles exceeds that of the aorta and the pulmonary trunk, both of the SL valves will open and we'll get to ventricular ejection, which is where blood is officially pumped out of the ventricles into the aorta and the pulmonary trunk. Here is where we're going to have a change in the volume. Once blood has been pumped from the ventricles into our larger arteries, we're going to then enter the period known as isovolumetric relaxation. Now, to get from ventricular ejection to isovolumetric relaxation, we had to have the closing of the SL valves. So after the ventricles have pumped their blood into the large vessels, the pressure inside of the vesicles will eventually exceed that of the ventricles. And then that blood is going to start going backwards towards the ventricles. Fortunately, we have the SL valves that will close to prevent that blood from entering those ventricles. And when those SL valves close, that's going to lead us to this isovolumetric relaxation period. Again, just as with isovolumetric contraction, isovolumetric relaxation indicates that there will be no change in the volumes of any of the chambers. Eventually, as the ventricular walls continue to relax, their pressure is going to continually drop as their volume stays the same. And when the pressure in the atria then exceeds that of the ventricles, we'll be left with ventricular filling. Ventricular filling is allowed by the opening of the AV valves, and this will eventually go back to atrial contraction. So the phases of the cardiac cycle will tell you what mechanical events are occurring in what order in the heart. You can see that the heart is an extremely intricate and very, very specific organ, and it requires very close and precise regulation. Now, we have a couple other things on this slide that's going to be very helpful for our understanding of the cardiac cycle. First and foremost are the heart sounds. This diagram will nicely show you where S1 and S2 occur. We remember that S1 refers to the sound of the heart pushing back against the AV valves. So it would make sense that S1 occurs during the period of isovolumetric contraction. S2 is going to occur during isovolumetric relaxation. Now, we also see the pressure and volume graphs as well. Specifically, we're looking at the volume in the ventricles. And you can see that during atrial contraction, the volume of the ventricles is going to increase as blood is being pumped into the ventricles. This volume will stay exactly the same during the period of isovolumetric contraction, hence the name isovolumetric. Iso means same, and volumetric is going to indicate that we're looking at the volumes. Now, during the period of ventricular ejection, there's going to be a very, very significant change in the volume of blood that's found in the ventricles. You can see that we're going to drastically drop from about 130 milliliters all the way down to about 60 milliliters. And during the period of isovolumetric relaxation, the volume in the ventricle will also stay the same. Once we get to the ventricular filling stage, that's going to indicate that we're increasing the volume inside of the ventricles. Now, we're really dissecting this cardiac cycle very, very specifically. And you can see that we can do that with pressure as well. The pressure graph shows you in a couple different colored lines how the pressure is going to change throughout the cardiac cycle. The pressure in the aorta is shown with the red line, the ventricular pressure is going to be shown with the blue line, and the atrial pressure is going to be shown here in the green line. Now, specifically, these are showing us the left ventricle and the left atria, but what's important is that we can see the ventricles compared to the atria. So the main places that I want to show you are the isovolumetric periods. Since the volume stays the same and the ventricles continuously either contract or relax during these periods, that's going to show us a drastic increase and a decrease in the pressure during these periods. You'll also see on this slide that we have the specific opening and closing of the valves listed for you as well. So this is the cardiac cycle. This picture shows us one individual heartbeat and all of the associated events that goes with it. So in relation to the cardiac cycle, the heart sounds can be heard at different places using a stethoscope. And I'm sure you've all had the opportunity to have a stethoscope used on you to assess your heartbeat before. The first sound, also known as lub or S1, is caused by the AV valves closing. And the second sound, or the dub, or S2 as I'll prefer to call it, is indicated by the semilunar valves closing. And I'll just re-mention here that heart murmurs refer to inappropriate heart sounds. Sounds that are not supposed to be occurring in a typical cardiac cycle. Backflow in one of the valves can lead to heart murmurs, as well as valvular stenosis, which is the narrowing of the valves. So we're now going to switch gears a little bit and start talking specifically about cardiac physiology. Cardiac physiology specifies on the volume changes that occur in the heart and how those are related to the blood pressures of the heart as well. We're going to use these volumes and pressures to calculate the health of the heart and also to understand how certain changes that occur with the cardiovascular system can have such a more systemic effect than just the localized change itself. So we need to add a few terms to our vocabulary before we go on. And the first of those is cardiac output. So cardiac output is a measure of volume. It is specifically the amount of blood that has been ejected from the left or the right ventricle into their major vessel each minute. Now, if you calculate this based on the left ventricle, you need to use the aorta, and if you use the right ventricle, you'll need to use the pulmonary trunk. So it would probably be good practice to stick with the left ventricle, as that's going to enter into the systemic circulation. So in short, cardiac output is the amount of blood that's ejected from the left ventricle each minute into the aorta. Now we can actually simplify cardiac output into this little equation down here. Cardiac output equals stroke volume times the heart rate. Now heart rate is measured in beats per minute. How many cardiac cycles occur within 1 minute? Stroke volume, on the other hand, is described here. The stroke volume is specifically the amount of blood pumped out of the ventricle for every single individual heartbeat. So based upon knowing the stroke volume, you can calculate the cardiac output by multiplying that to the heart rate. Since heart rate is measured in beats per minute and stroke volume is measured in milliliters per beat, we can use these two factors to give us milliliters of blood per minute leaving the heart. So a little example we have down here to practice with is if we have a stroke volume of 70 milliliters per beat, and this is pretty much natural, this is what we expect to see in a normal heart. Using our normal sinus rhythm of 75 beats per minute, we can multiply these together and end up with 5,250 milliliters per minute. But if we convert this, we end up with 5.2 liters per minute, which tells us that almost all of the blood in our entire cardiovascular system circulates through the heart every single minute. We got this number from the blood presentation, understanding that there's roughly 5 to 6 liters of blood that's found within the heart and the blood vessels. So we now know that cardiac output is a measure of volume. It can be calculated from multiplying the stroke volume by the heart rate, and it can be defined as the amount of blood that is leaving the left ventricle every minute. Now we could assess the heart rate by sitting and listening to the amount of beats that occur within 1 minute. This would be a much more effective reading if our patient was relaxed when doing this, so their heart rate wasn't changing during the course of that minute. But that is one way that we could calculate heart rate, is by sitting there and listening to the patient's heart rate and counting the amount of beats that occur within 1 minute. However, we need other ways that we can calculate the stroke volume, and we do that using the EDV, the end diastolic volume, and the end systolic volume, which is our ESV. And the formula for stroke volume is the end diastolic volume minus the end systolic volume. So let's define each of these terms. The end diastolic volume is the amount of blood in the ventricle at the end of ventricular diastole. So ventricular diastole is the relaxation of the ventricular walls. As the ventricular walls are relaxing, they're going to open up and stretch as blood is getting pumped into the ventricles. At the point where the ventricles are relaxed enough to where we get the maximum amount of blood in the ventricles, that volume is the end diastolic volume. Now the end systolic volume is going to be just about the opposite. This is the amount of blood that's remaining in the ventricle after the ventricles have undergone systole. So once the left ventricle contracts and squeezes that blood into the aorta, there will still be a little bit of blood remaining in the ventricle that did not get pumped into the systemic circulation. So we will take the end diastolic volume and subtract the amount of blood that was not ejected from the left ventricle, and that will give us our stroke volume. You can see that normally we have an end diastolic volume of about 120 milliliters, and there will be about 50 milliliters left in the ventricles after systole. And that gives us our stroke volume of 70 milliliters. You can see that not all of the blood in the ventricles is getting pumped out. We'll end up having this end diastolic volume that will be a much larger volume. That's whenever the ventricles are going to be relaxed. And once the ventricles have contracted, we'll be left with this amount that's remaining. So we never really fully empty the ventricles. So in review, we have cardiac output that would equal the stroke volume times the heart rate. But we could plug in for stroke volume the end diastolic volume minus the end systolic volume. There are quite a few factors that are going to affect the stroke volume, namely preload, contractility, and afterload. And these are some concepts that we're going to talk about next.